How many? 29 students. Good evening. Good evening, LVK. I am here.
Good evening, sir.
I am doing some background issues.
I've sent you the PPT, but you want me to share? I'll try to share it. Sir.
Okay, that is not an issue. If you have the slides ready with you, we can share after our initial thing. I am just looking at a technical issue.
Can I just try sharing it, sir?
I have seen it. You could. Okay. By the time we start, I will stop sharing my screen.
Okay.
Okay.
I try sharing the thing?
No, I will. I will request you at that time.
Okay.
Jayanti ma'am will take a little more time.
I've reached.
Okay, great. Okay.
I'm on.
Just give me 1 or 2 minutes.
I just reached on time. Good evening. I'm in uniform today.
In uniform.
Just came back.
Came back from Global. Global Peripheral Clinic is there. So I just go on Monday and Thursdays. It's a 45 minutes ride.
Okay, Sojan, everything is ready, no?
We came to know that there's going to be a conventional exam, okay? Not OSCE, most likely.
So it will be conventional exam.
That's the message we got today.
Okay.
And ISG National Forum is starting clinics on Sundays. So
I am supposed to on 1st August there's a discussion on diarrhea. They already informed me and invited me.
clinics on Sunday.
It's Sunday.
Mine is on 8th.
Ma'am, yours is on 8th.
8th. Clinics is on 8th.
Can we start then?
Sir, I think I am sharing on Facebook, so that would be recorded there, I think, sir.
Okay, you are sharing on which Facebook? ISGK?
ISGK PG Clinics. I think
you are able to do that, no? Then you start doing it. Okay. And also please record.
Yes, sir, I'm recording in case some issue happens. Right, sir.
Okay, record on Zoom also.
Right, sir. Right, sir. We'll do that.
Okay. Once you start, we can.
We are ready, sir. Ready, sir.
Okay. Good evening. Welcome to ISGK PG Clinic. For today's discussion, we have Professor L. Venkatakrishnan, who is the Professor and Head of GI Sciences, PhD Institute of Medical Sciences and Research Center, Coimbatore. And along with Professor Venkatakrishnan, we have Professor V. Jayanti, the Professor of Hepatology from SRMC, Chennai. Both of them are very good teachers, and I would say most sought after teachers in India. And students always look forward to a discussion with Professor Venkatakrishnan and Professor Jayanti. And for today's discussion, we have Dr. Vivek from Global. Are you there?
Yes, sir.
Okay. Dr. Jagdishwar from KIMS.
Yes, sir.
And Dr. Snija from Aster in case of any technical issue as a standby person. Okay. So without much delay, we will start the discussion, and Professor Venkat will be discussing 2 liver cases. So I am stopping sharing. Professor Venkat, please share your slides.
Thank you, sir. Slides are not moving. Can somebody share?
You want me to do that?
It is seen, LVK. Just
Yeah, but I don't.
slide.
Oh, not
Connected.
LVK on the bottom left side, if you press on the zoom, there will be it is actually very mildly visible. There's a forward and backward arrow on your zoom screen on the bottom left. If you move the cursor, then you will find.
It's moving.
But I just want
next slide. Just put the next
slide
slide.
show. I'm not getting it.
It's there. It's already slideshow.
Just try to move it forward and backward.
It's slideshow mode.
Okay, then if there are any problems, I will do it.
Can you share it, sir?
I will do it.
LVK, it was open in slideshow mode.
Oh, it was in Google format.
Vivek, your voice is not very audible. So be loud and clear.
Is it audible now?
Be a little louder.
Yes, sir.
Very soft it is.
Now, ma'am?
You raise your voice when you're speaking.
Are the slides visible?
Slides are visible, yeah. Put it on
They're visible, sir.
But not in slideshow.
Slideshow.
Okay.
Yeah,
Fine.
fine.
Okay.
Start. Next slide.
Yeah, next, sir.
Okay.
Good evening,
We
sir.
are ready. Vivek, you please take up the discussion. Okay.
Yes, sir. So, 50 years old female, known case of
Little
hypothyroidism.
louder, doctor.
Known case of hypothyroidism on regular treatment. Complaints of abdominal distension, pedal edema, breathlessness, decreased urine output, generalized itching, and symptoms are for 1 month. To expand on the history. So, sir, I would like to know whether abdominal distension, how was the onset?
Can you
Whether
be louder, doctor, please?
Yes. I would like to know whether abdominal distension was acute in onset or gradual onset.
No, it's a gradual onset of abdominal distension. All these symptoms are for 1 month. She was on a regular, she's a hypothyroid lady. She was on regular treatment. Then she came to us with abdominal distension, pedal edema, breathlessness, decrease in generalized itching. All symptoms are for 1 month. It was all gradually going up.
Okay, sir. And abdominal distension and pedal edema are same time of onset, not for, one followed by another, sir.
What is it?
Abdominal distension and pedal edema, whether distension was first, then pedal edema, or both?
Abdominal distension and pedal edema was initially present, and then she had breathlessness and decreased urine output. But
Almost simultaneous, Vivek.
almost simultaneously.
Okay. Breathlessness, I would further like to ask whether it was with exertion or was it at rest, whether there was
The breathlessness was initially exertional dyspnea, and then later, as the abdominal distension progressed, she was not able to lie down.
Okay, sir. Any paroxysmal nocturnal dyspnea was there previous to that?
No.
Okay, sir. Then there was also generalized itching. So I would like to know whether it was first initially started.
Anything else you would like to ask in breathlessness? Just keep all the causes in mind. And any other questions you would like to ask?
Any orthopnea, platypnea was there along with that. Whether it was more in supine position.
Yeah.
That I would like to know.
Because she was exertional, but as I told you, as the abdominal distension became progressive, she was not able to lie down.
Okay, sir. Then for generalized itching, whether the onset was in initially palms and soles followed by generalized itching, or from?
No, it was a generalized itching. There was nothing like starting with palms and soles, and then it was a generalized itching. And she's been on treatment for hypothyroid for more than about 10 years now.
What else did you ask for itching? When did you get some itching?
Ma'am, any other history of jaundice or pale?
Exactly. Yeah, that's what you should ask. No? Jaundice, LVK?
Madam?
Asking whether the patient had jaundice.
There was no history of jaundice. She never complained of any jaundice. There was no history of jaundice.
So when all can you get itching without jaundice? Common conditions, common. Recent diabetes, kidney disease, they all can just present
hypothyroidism, all this.
Just a dry skin. So just keep that in mind. Once jaundice is not there, and these are the possibilities. What else would you like to ask quickly? Quick.
Along with that, ma'am, I will like to ask any loss of appetite, any weight loss was there associated with that?
Can we go to the next slide, sir?
Abdominal pain, no? This is abdominal pain.
So there was
no yellowish discoloration of eyes, generalized pruritus all over body, no abdominal pain. There was gradual abdominal distension and progressive pedal edema. There was no history of GI bleed, no history of altered sensorium. Breathlessness on exertion was present, and patient was unable to lie down due to abdominal distension, and recent anorexia with gradual decrease in intake was also there.
Yes, you'd like to ask?
Apart from this, any history of fever?
Fever,
cough,
synthesis, diet. Keep asking, quick, you must ask, no?
Polyuria, polydipsia.
Questions you'd like to ask? Any tapping done? It was a rapid reaccumulation. What was the color of the fluid if tapping was done? Was she put on diuretics? These are, the thing is, in case you're having a conventional type exam, you know that it's a liver disease, no? So you just have to build up the whole history in a short span of time. You already know this. Once you get oliguria with abdominal distension, you know that it is a liver disease. So don't keep wasting time, So what else would you like to ask?
Apart from this, ma'am, any investigations were done outside, any blood investigations or any proper GI endoscopy?
My audio is no.
It's very weak.
I'm not able to hear you, Dr. Vivu.
So I will try to.
But I am able to hear.
Still faint.
Yeah, go ahead. Yeah.
Yes. So patient was unable to lie down due to abdominal distension and recent anorexia.
Yeah, as abdominal distension progressed, she was not able to lie down. She was no breathing. That's what we discussed. But she, as abdominal distension progressed, she was not able to take, and there was anorexia.
Yes. Whether, sir, anorexia, whether there was postprandial fullness or early satiety was there associated with that?
She just felt that she's not able to eat anything. She does not tells me there's an early satiety or postprandial fullness or anything. Just said that her intake has come down because the abdominal distension was gradually progressive, along with the pedal edema.
Any questions you will ask for MHE?
Any recent change in, if she's literate, then any recent change in handwriting pattern or
Yeah, sleep pattern. First is
sleep
sleep.
pattern,
Confusion or any difficulty in writing, or she found that she was able to go and not able to put on a switch. All those things. She's a lady, so all these things we need to know whether it's an MHE. Okay.
Which is important.
Any other history you want?
Sir, apart from this, any history of complementary?
Basically, a 64 hypothyroid has come with a progressive edema, abdominal distension, and recent anorexia and breathlessness on exertion. There's no history of any altered sensorium, but she has got a generalized itching.
The thing is just for 1 month,
All for 1 month.
An elderly lady. So what are the things that can happen in an acute? It looks like it is like a liver disease. So when can you get an acute onset of presentation of a liver disease? That's your differential. So what else would you ask? Any paraneoplastic manifestation?
Any hypoglycemia? Any?
Because you do not know. Maybe a liver disease and underlying sudden decompensation. That's a natural history of any HBV, HCV, NAFLD. All this NAFLD in fact comes out much earlier. But these ones will come on around 65 years, when they actually go in for a decompensation in HCC. To keep all the complicated bleeding, diathesis, these are the questions that you will ask. MHE, sleep pattern. Then breathlessness, we already sorted it out. GI bleed, you sorted out.
Volume.
And then important is that you have to ask for the treatment. What for the 1 month, have any investigations done, and was there any treatment that was offered to her? So then that gives you an idea. And CAM history, you did ask a question. We need to know that as well. You did ask for that. So CAM history is important. And whether she was already a known case of chronic liver disease and was she on a long-term treatment. Is that important?
Yes, ma'am.
That is important, Supposing I had a patient today, 40 years back, she was diagnosed with HbCG positive, and she's come after 40 years. You understand? So that history is important. That was she already a diagnosed liver disease, or she's had a liver disease right now. So those are the things that will give you a clue. Is it a sudden decompensation with a new onset of a new disease, or it's already a pre-existing liver disease and patient is decompensated? Got it?
Yes, ma'am.
LVK summary exit, or we proceed? Some more history?
So, she's a 64-year-old lady who has come with progressive abdominal distension, generalized pruritus, pedal edema, and she has got a breathlessness. There was no history of GI bleed or anything. She didn't have any altered sensorium. No features of thing, no previous, she did not notice any jaundice or high colored urine recently. She didn't have symptoms like what madam said for, say, paraneoplastic like hypoglycemia or something. So a 64-year-old lady with a progressive abdominal distension and so can you go on?
Yes. So past history, 2018 patient had pedal edema and ultrasound.
How important it is. All this you should have asked. I didn't know the case, So basically, this is what you should ask. Are you already, just like I said, 40-year-old back, HPCG, if it comes to me decompensation now, then I know what the disease is. Very important. So you just have to ask, was she already a diagnosed case? Was she on any specific treatment, or is this the first time? If it's the first time, then HCC comes as top on the list. Because there's a sudden decompensation in a pre-existing liver disease. I mean, my diagnosis will be almost right there. Okay, read on.
2018 patient had pedal edema. Ultrasound abdomen showed coarse liver, found to be HCV positive. She was given oral medication for 3 months, and upper GI endoscopy was done, and she was told to come if there is melena or hematemesis. She is not a diabetic or hypertensive. No history of CAM intake. Now able to take only 1000 kilocalories per day, and recent ultrasound shows coarse liver and moderate ascites.
What is your comment on coarse echo texture of the liver?
Yes,
So she had 2018, she had a pedal edema. She had a coarse liver and found to be HCV positive. She was given she has been treated elsewhere, was given oral medication for 3 months. And there was an endoscopy and she was told if there's a melena hematemesis. So what do you inherit from here?
So she was treated with directly acting antiviral agents, most likely for...
No, what do you inherit what she has?
She has hepatitis C virus with chronic hepatitis C with cirrhosis of liver, most likely.
Maybe chronic hepatitis C. One, she has got a chronic hepatitis C. She is likely to have cirrhosis of liver or F4 fibrosis because
she had upper GI endoscopy was done and she was told if there is melena and hematemesis, then she...
probably there would have been varices. Probably there would have been varices because she was told to come if there's any melena or hematemesis, and she was given oral medication for 3 months. So what medication could have been given?
Sir, mostly sofosbuvir, velpatasvir with ribavirin.
No, direct antivirals.
Direct antivirals.
You want to say she would have been given 3 months means maybe she has been given, we don't know. For 3 months, we presume.
Direct antiviral.
Direct
acting antiviral agents for...
Direct antivirals. So she got it. So beyond that, what are these? So at this point of time, what would you have asked what would you have asked the patient? What are the questions you would have asked her? See, this has happened 3 years back, 2018, June it happened.
Sir, whether after how many tablets were given, like sofosbuvir, like it was...
No, you can't see. She won't know, man. She comes from a place called Tondamutur. Okay, it's a village here, next about 8 kilometers from our place. So she lives in her farm.
Sir, whether she has done any repeat blood testing after 3 months?
Yeah, exactly. Was there any blood testing done after?
After 3 months of completion of treatment.
After 3 months and
any ultrasound abdomen she's...
No. Any blood test been done after the treatment after 3 months and how many months?
Whether repeat course was suggested or what was the patient told? Whether...
No, when do you look for SVR?
SVR. When do you look for SVR?
12 weeks and or 24 weeks after completion
12 weeks and 24 weeks.
24 weeks. SVR.
12 weeks and 24 weeks. So any medication was, any testing was done to her after 12 weeks or 24 weeks or 6 months. Then any other question you would ask her? You are expecting her to be a HCV cirrhosis.
Yes. In between, sir, she had any abdominal distension or pedal edema?
No. You would have asked whether was she put on any surveillance. Isn't it? Was she asked to come for a
ultrasound abdomen
6-month surveillance?
Why is it important?
Why is it so? Why did I ask for a 6-month surveillance in this patient?
Because, sir, despite even we treat patients for hepatitis C and they achieve SVR, there is still risk of developing hepatocellular carcinoma. There is still risk of developing hepatocellular carcinoma even if after achieving
exactly
SVR.
In a patient with HCV related fibrosis or cirrhosis, despite having SVR, you need to put them on.
6 monthly
surveillance. Because
patient can develop hepatocellular carcinoma and
because even after SVR, you can still have a liver-related mortality if the patient has got cirrhosis of liver or F4 or fibrosis. If you have F3 or F4 fibrosis or cirrhosis, despite having an SVR, you can have a liver-related mortality. So basically, this patient was given for 3 months of 3 months of oral medication. We don't have any idea whether she was looked for a
SVR.
sustained biological response, and there was no history of that she was asked to come back for any regular surveillance for the next 3 years.
And,
She is not a diabetic or hypertensive. Why is it so important that she is a diabetic or not diabetic?
Sir, if she is diabetic, then with HCV, there is increased risk of developing hepatocellular carcinoma as well.
Pardon me?
Sir, diabetes is also a risk factor for developing HCC. So with HCV,
Oh, it is not the development of HCC per se.
worsening
If you are a diabetic, you can still decompensate after SVR in patients with cirrhosis of liver. That is the importance. Okay, let's discuss it later. Then
there was no history of CAM intake.
no history of CAM.
Ma'am has asked for 3 months versus 6 months treatment in cirrhosis of liver. So
Yeah.
We will, when we are giving it along with ribavirin, and 6 months if we are.
If you are a cirrhotic, if you are giving ribavirin, you give for 3 months. But if you are having cirrhosis, you are giving without ribavirin,
then 6
you
weeks.
take 6 months. That's a recent ASLD guidance on Hep C treatment. Okay.
based on this, do you think the itch, can you correlate the itching in this patient now? Anything that could have happened to her?
Hepatitis C per se can also cause cholesterol. But
jaundice. Is it possible that she has a renal pathology?
Hepatitis C can also cause porphyria and
what are the renal changes? LVK's favorite question.
Renal changes are one membranoproliferative glomerulonephritis with HCV, and another is cryoglobulinemia can happen as extrahepatic manifestation.
I think that those are the things that you should consider.
No history of CAM.
Now she is able to take 1000 kilocalories per day.
1000 kilocalories per day.
Next slide.
And she went back to the same doctor, same place where she was treated.
Next slide.
And the recent ultrasound showed coarse liver and moderate ascites.
Slide. Previous slide.
So
summarize.
So what do you think this patient could have had now?
Yes,
so she is a 64 lady, hypothyroid. She has got hepatitis C positive. She was found to have a coarse liver with possible varices. Then she was okay for 3 years. And after that, now she has come back with pedal edema, progressive abdominal distension, anorexia, breathlessness, and edema.
Sir, one can edema, be
and now the present ultrasound again shows moderate ascites. But means 3 years she would have been she was doing well, and she's got now intense pruritus. So 3 years she's been doing well, and now for the last 1 month she probably has now decompensated. She has now come with ascites and pedal edema. So what do you think what do you think is happening to this patient?
So one can be further decompensation of already previously present cirrhosis of liver.
Pardon me?
Sir, decompensation of cirrhosis of liver, first possibility. Second can be
decompensation of cirrhosis of liver due to what?
Can be, sir, due to either reactivation or the previously hepatitis C virus was not treated as she has not checked SVR.
So, one you think is could be a relapse of HCV?
Yes. One can be relapse, and another can be.
It could be a relapse of hepatitis C. The point here is one is so relapse of hepatitis C. Number second. Relapse of hepatitis C could have been due to?
You just answered it now.
He might not have achieved SVR also.
Yeah, one is she could not have achieved an SVR, but it's possible she would have had an SVR. She would have had an SVR because she was quite okay for some time, for nearly 3 years, or she would not have an SVR. Number 2,
relapse.
she could have had an early virological response, an SVR, and then she could have had a drug resistance, isn't it? Drug resistance. Number 3rd,
so development of hepatitis.
What are the liver-related complications in a patient with HCV? Why do they decompensate after SVR? One, you said they would not have achieved an SVR. Number 2, we think it's a HCV resistance. Number 3,
sir, they have steatosis also, steatohepatitis changes also due to hepatitis C person.
they may have another comorbid like a NAFLD, NASH, or nothing steatohepatitis. What are the risk factors for decompensation in hepatitis cirrhosis after you achieve a SVR or after you get treated with a DAA?
Diabetic patient is
diabetes, number 1.
male,
number 2,
male gender is another.
Male gender, alcohol abuse,
any co-infection with hepatitis B.
There could have been a coinotic, but she would have come with icterus. So it could have been a relapse. Then after SVR, it could be incomplete regression of the portal hypertension and
development of
and associated metabolic MAFLD, metabolic associated fatty liver disease. So male gender, age above 60, incomplete, it could have been incomplete SVR, or she would not have achieved an SVR. It could be a drug resistance, it could be alcohol abuse, or it could be associated MAFLD and presence of diabetes. Diabetes itself could be one of the reasons why your liver-related morbidity is there. So if you treat chronic hepatitis C and achieve an SVR, what will be the incidence of liver-related problems in a chronic hepatitis C? How much percentage?
Around 10%, sir. I am not.
No, it's only 0.67%. If you have a chronic hepatitis C and you treat, you achieve an SVR, your chance of developing a liver-related mortality is 0.64% per year. But if you have a cirrhosis and you still achieve an SVR, the percentage of people who can go in for a liver-related mortality despite SVR per year is 2.57%. So this is important that you said rightly that you can have still a liver-related mortality or a morbidity after SVR in certain situations. And if you said correctly that if there is F3 or F4 fibrocirrhosis, the risk of HCC does not go away despite you having an SVR. Okay, so these are the reasons why this could all be liver-related causes for which she has developed a pedal edema and a portal. Then the other thing you should think of is autoimmune liver diseases. Elderly lady, hypothyroid, and another associated autoimmune liver disease could have decompensated her. So these are the 5 or 6 points why you think you will decompensate in SVR to this one. Madam said portal vein thrombosis and of course HCC. These are the 5 things which could have caused her to have a thing with it. So what are the non-hepatic related things? HCV can lead on to pedal edema and ascites. So here liver-related problems will be post not achieving SVR, drug resistance, associated diabetes, associated alcohol abuse, male, age above 64 years, associated MAFLD, associated new onset of autoimmune liver disease and portal vein thrombosis and HCC. So these are things which can come to you after this. Can autoimmune liver disease can be precipitated by hepatitis C? What are the extrahepatic manifestations of hepatitis C you should know?
Sir, one is
Discussed it, mention it.
cryoglobulinemia, membranoproliferative.
Most important thing is MODY, mature onset diabetes mellitus. You can get it. Then you can get thyroid abnormalities. You can get autoimmune liver disease. You can get Sika syndrome. You can get polyarthralgia. And then you can get cryoglobulinemia. All those things. So can there anything unrelated to liver? Can this patient on Hep C develop this one? Can develop a pedal edema and ascites?
Due to glomerulonephritis, they can develop sometimes nephrotic syndrome. Then due to glomerulonephritis,
they can develop a glomerular disease due to cryoglobulinemia or non-cryoglobulinemia. Okay, so when you can develop a nephrotic range of proteinuria in hepatitis C. Can hepatitis C itself, can it explain your pruritus?
yes, sir. Hepatitis C per se can cause cholestasis.
It can cause bile duct injury. It can cause bile duct thing. So it can cause itself a pruritus. Okay. So probably she has all these are the probabilities you'll think of in this particular patient. In patients who have been treated with this year. Go ahead, please.
On examination, mild icterus is present. Blood pressure is 110 by 50 millimeter of mercury. There is mild pallor and thyromegaly, bilateral pedal edema, generalized ichthyosis, no distended veins. Abdomen is distended, flanks are full. Left lobe of liver is palpable. Spleen is palpable and free fluid is present. Right-sided chest shows dullness and reduced air entry.
The neck veins are also not distended.
So, my syndromic diagnosis.
No, here, she's got a mild icterus. She has no nodes. She has got free fluid in the abdomen. She has no distended abdominal veins. She's got left lobe of the liver is much more prominent than the right lobe. She's got a spleen and she has got a reduced air entry the right side. So what do you think she has now?
Sir, patient, she has cirrhosis with decompensation. That is my.
No, she's got one chronic HCV infection post-treatment. Syndromic diagnosis, number one.
Chronic HCV with cirrhosis of liver and portal hypertension. Now decompensation in form of ascites, pedal edema, and mild jaundice, but without any.
No, there's a decompensation because there is jaundice, there is ascites, there is pedal edema. She's got portal hypertension because she's got a spleen, and she's got a breathlessness. Neck veins are not.
No, sir. Not.
Neck veins are not full. Thereby, you're ruling out a cardiac dysfunction or a hypothyroid can produce neck veins. How do they hypothyroid can produce neck veins?
Due to compression of
mixed edema can produce pericardial effusions. Okay, so that is not there, and you have a right-sided dull air entry. So what do you think she has got?
She also has right-sided pleural effusion.
Pleural effusion. It could. What do you call that?
Hepatic hydrothorax.
Hepatic hydrothorax. So probably she's got a decompensated chronic liver disease. She's got a portal hypertension. She's got a right hepatic hydrothorax. And in a patient who's got a hypothyroid and treated for Hep C 3 years back. So what will be the possibilities for her recent decompensation? Yes, same thing as what we discussed, isn't it?
Yes.
Can you recapitulate what we discussed?
Yes, sir. One is patient has not.
Could be a relapse of HCV infection. Number two.
Patient has not achieved SVR, so failure of directly acting antiviral agent. That is second possibility.
Could be other associated risk factors like
Another like
portal vein thrombus or
hepatocellular carcinoma.
Correct. And then
Or it can be
or this decomposition could have been driven by not related to HCV, like
autoimmune hepatitis underlying.
She doesn't consume alcohol, so it could be an associated NASH related cirrhosis.
Autoimmune hepatitis.
An autoimmune liver disease. She's got intense pruritus, so she may have a primary biliary cirrhosis, something like that. Autoimmune liver disease. Okay, two things. Okay.
So investigations: hemoglobin 8.9, total count of 3,100, and platelet 72,000. There is pancytopenia, and neutrophils are 72%. MCV is also high, 107. Urea is 36, creatinine 0.78. Sodium is 120.
So here you have a hemoglobin, you have a pancytopenia and a thrombocytopenia, isn't it?
Yes, sir.
Okay.
Yes, sir.
So she's got probably cirrhosis and
Portal hypertension.
Platelet are low, and she was already treated for HCV. She's got cirrhosis. So what are the two risks you will always expect when somebody has got cirrhosis and a low platelet count in the presence of ascites?
One can be, sir.
Somebody is ascites, has now decomposed, got a low platelet count.
Portal vein thrombosis.
No, when you have a low platelet, what are the two risks they can have? When you walk on, what are the two risks you can anticipate in a cirrhotic patient who has got ascites complicated by a thrombocytopenia?
HCC is one possibility. There is thrombocytopenia.
What risk increases when you have a low platelet and if your LSM goes up?
Sir, hepatocellular carcinoma risk increases.
Yeah, one is HCC, number two, esophageal varices, isn't it? When you screen for esophageal varices, you screen if you are. When do you screen for esophageal varices? In a patient who has got a chronic liver disease.
Less than 1 lakh.
If your liver stiffness measurement is more than 15 kPa or if your platelets are less than
1 lakh.
1.5 lakhs. This is what you screen. Okay. Go ahead, please.
Urea is 36, creatinine 0.78, sodium is 125. There is hyponatremia.
Sodium is 125, potassium is 4.2. So when you see a sodium in this patient who is fluid overloaded and a sodium of 125, what are the possibilities in this patient?
Sir, one is dilutional hyponatremia, most likely.
So one can be a dilutional hyponatremia in this patient. Number two?
Sir, can be due to acute kidney injury also. But
pardon me?
Acute kidney injury, HRS.
I'm not able to hear you, doctor. Somehow I'm not able to hear you today.
Acute kidney injury, sir. Second possibility.
One is dilution of everything, or there can be a relative adrenal insufficiency in this patient. So when you have a dilutional hyponatremia, in this situation, what are the other investigations you would like to ask this patient?
Sir, I will ask for urine osmolality and urine sodium as well as
osmolality and then urine spot sodium.
Urine spot sodium.
Because it should have been put on diuretics. If the urine spot sodium is more than 20, then probably it was more of a depletional, and less than 20. Then because she was HCV. Okay, go ahead.
Liver function test showed bilirubin total 2.6, direct 2.8, direct 2.6. ALT.
SGPT is 47.
47. AST is 86.
SGOT is 86. Alphos is 104.
GGT is 108.
Gamma GT is 108.
Total protein 6.5 and albumin is 2.5.
Yeah.
There is a reversal of albumin globulin ratio, and ALT, AST are also ALT is 1 time elevated, almost near normal, but AST is 2 times elevated, 86.
No, she's got AG reversal. Then thyroid profile.
Free T4 is 1.4 and TSH is 0.73. So both are normal. And
Yeah, that's normal. What is us?
hepatic fluid total count is 400 and neutrophil is 12% with protein of 1.4 and albumin of 0.9. So patient is
You
having
got a low protein, high SAG ascites.
serum albumin to ascites.
Urine routine is 2 plus and RBC is 30 to 50. What next you would like to do this?
Sir, I will.
What else will you ask in the urine? Favorite question.
Urine albumin is 2 plus, RBCs are 30 to 50, and there were few casts.
What else will you ask in urine?
Ask for 24-hour urine protein as well as ultrasound abdomen.
So urine PCR itself was
PCR.
2.2.
So many times sir has discussed, no?
Urine PCR is 2.2 here. That means she has got significant proteinuria in this. So if there is significant proteinuria in a patient with HCV, what do you do next?
And diabetes. And diabetes, no?
So she is not a diabetic man.
On diabetes, no? Okay.
Hypothyroid.
Okay.
What do you do next? Urine proteinuria. You are the consultant on rounds and I tell you that patient has got a PCR of 2.2 in a HCV related, in a patient who has been treated for HCV, now he has got cirrhosis.
Sir, renal biopsy to find out.
I think you need to look for a cryoglobulin, isn't it? You can look for urine for cryoglobulins or you can do a serum cryoglobulins. And you also do a C3 and a C4 level. If there are glomerular diseases, both these things will be, and cryoglobulins are positive. We did it actually. Cryoglobulins are negative and C3, C4 were. C3 was less, C4 was normal. So possibly she may have a HCV related.
Speak loudly with confidence, Vivek.
What will she have? If you have a HCV disease, she has got a significant proteinuria, absent cryoglobulins, low C3, normal C4. What does it suggest to you?
Sir, glomerulonephritis antigen.
Glomerular disease. And what are the two glomerular disease you can get in hepatitis C?
Sir, membranoproliferative glomerulonephritis.
Yeah, this is likely to be membranoproliferative because you have a lot of RBCs, or it can be membranous. Okay? Or it could be membranous. So these are things. So it is possible that this lady has got dilutional hyponatremia. She's got this. She's got low globulin. She got a high protein, low protein, high SAG ascites, and probably we are treating with a glomerular disease, associated glomerular disease. That is what we have on this. Okay. Can we go? What do you want next?
Sir, I will ask for ultrasound abdomen with portable.
Ultrasound was already done. Ultrasound was already done for her when she came. So we got an X-ray chest on her because she had clinically possibly you said a hepatic hydrothorax. So this was a chest, and once you see this, what do you do next?
Moderate right pleural effusion is there, so I will ask for.
Pardon me?
Moderate right-sided pleural effusion is there, hepatic hydrothorax.
Yeah, what do you do next?
Pleural fluid paracentesis.
Can we have the next slide? Pleural fluid counts is 1800.
And the neutrophil is 60.
Neutrophils is 60. Protein is 1.7. Albumin is 0.37.
So patient.
What does she have?
Spontaneous bacterial empyema.
So she's got a spontaneous bacterial empyema.
Speak with confidence, Vivek.
She's got a bacterial. So she has got a dilutional hyponatremia, spontaneous bacterial empyema, and a glomerular disease. What is the commonest cause of hyponatremia in a cirrhosis? If you see hyponatremia, what will you look for first in a patient with cirrhosis?
Sir, fluid overload ascites with.
Pardon?
Ascites with pleural effusion where the patient is having.
No. If you see a hyponatremia in a patient decompensated cirrhosis, so your registrar asks you that patient is in a casualty and he asks you that patient has got 125 sodium. What is it you will ask them to do? Look for first. Commonest cause of hyponatremia in cirrhosis.
Can be diuretic induced and
Huh?
there's a diuretic induced one possibility. Second is dilutional hyponatremia. And
Number 1 is infection. Number 2 is infection. Number 3 is infection. So the commonest cause of hyponatremia in a cirrhotic patient is infection. Okay. So exactly what she has is a spontaneous bacterial empyema. Okay, now we have an endoscopy done on 6/7. She had grade 2 varices in 3 columns and portal gastropathy. We did, why did I do an ANA profile and a liver profile? Our liver profile will include LCA, will include LKM, AMA, M2 and SLA antigen. Why did we do?
This patient is already having is known case of cirrhosis, and now she is also having complaint of pruritus. So considering that, for finding out the cause of decompensation also.
Yeah. So one, to rule out any other, if hepatitis C has already been treated, is there an associated autoimmune liver disease? Because she has come with a pruritus. So is there any other autoimmune liver disease which we wanted to check? So we checked both on that. We rechecked our HbSAg and
Total anti-HBC.
And which was negative.
Total negative.
And
is positive.
Somebody asked, should we routinely do pleural fluid as hepatic hydrothorax? We have to do it for reasons, because every hospital admission, if you have a hydrothorax or ascites, even if everything, you need to do a search for infection. Please remember, they don't come with pain, they don't come with fever. When you have, can you go back now? When you have an infection, they can come to you with decompensation, they can come to hyponatremia, they can come to you with new onset of AKI, and they can come to you with encephalopathy. So you need to rule out infection in this. Second point is, let me talk to that little later. HCV remains positive. We did thyroid antibodies mainly because she had a HCV disease to see this in autoimmune liver disease. Thyroid antibodies were
423.
Were negative. Okay, so she doesn't have an autoimmune liver disease. She has a dilution hepatitis. She's got SBE, and she has no AKI, and she's got a dilution hypernatremia on this one. Okay, so can we? So what else you want now next?
Sir, I will also ask for alpha fetoprotein.
You wanted ultrasound, but we did ultrasound earlier. They have come and done. So you need to rule out 2 other things commonly in this.
One, I will ask for alpha fetoprotein, and second, I will also ask for hepatitis C virus.
Alpha fetoprotein was 4.6. The next, what do you want to do?
Sir, I will go for CT abdomen with.
What is the purpose of your CT abdomen?
Sir, to find out any hepatocellular carcinoma and to look
any
for
presence of HCC,
any portal vein,
or there's any presence of portal vein thrombosis. Okay.
So, CT abdomen plain with arterial enhancement and portal venous phase 3 and then there is liver is cirrhotic. I am not
Sunken liver. No obvious SOL, no obvious portal vein thrombosis. Can we have the next slide?
Splenomegaly, no? No splenomegaly.
Just, can you go to the next slide, please? Next slide. Previous slide. So what she had was only a chronic parenchymal liver disease. There were a lot of multiple collateral veins. There was no SOL in the liver. The right lobe is grossly reduced. That's why you're able to palpate only the left lobe. The spleen was the thing, but there was ascites. So we have ruled out a portal vein thrombosis and SOL. There is no autoimmune liver disease. She had normal thyroid profile, and she possibly has a glomerular disease. Okay, she has got probably a membranous proliferative glomerular nephritis. So if you can summarize what all she has now.
Yes, so 69
she's got a decompensated chronic liver disease. Number 2.
Second is portal hypertension with.
She's got a portal hypertension.
With decompensation in the form of ascites.
No, she got a portal hypertension, decompensation because bilirubin is up, PTINR is up, There's a low platelet.
Spontaneous bacterial
She's got
empyema.
ascites. She's got portal hypertension because she's got splenomegaly and varices. And she has got a nephrotic range of proteinuria with active sediment in the urine.
Spontaneous.
She's got a glomerular disease. And she has got a dilutional hyponatremia.
And hydrothorax.
And she's got a hepatic hydrothorax.
Hydrothorax.
With a
Spontaneous bacterial empyema.
with a
Spontaneous bacterial empyema.
the spontaneous bacterial empyema. There is no evidence of SB and all. So what has really driven her now to this one? So can we go to the next slide? Next slide, please. Okay, I did an ANA-IF. Okay. Supposing this patient has ANA-IF positive, you think this is HCV disease? Or before we check the RNA, when do you say that she has got is an autoimmune disease? Is it a antinuclear body is true positive or false positive?
Sir, for even if any other etiology is present, then
Pardon me?
sir, as hepatitis C is already present, we have
So if hepatitis C is positive, somebody is ANA-IF positive. When do you say that ANA-IF is significant?
Sir, more than
Because if she's ANA-IF significant, that also could have induced a glomerular injury for her, isn't it? So when do you say that ANA-IF is significant? At what titer?
more than 1:80.
1 in?
1:80.
1 in?
1:80.
1 in 160, some says, but in some of the autoimmune policies, 1 in 320.
320.
You look at autoimmune hepatitis redefined working group from Germany. If somebody is hepatitis C positive, it's more than 1 in 320 is only ANA positive. Okay, because if it is more than 1 in 320, it is possible that she may have something autoimmune which is driving her decompensation, driving her to get a glomerular disease. But I negative, we checked her HCV RNA.
HCV RNA is 1
Is it high or low?
high, sir. 1,06,000.
Is it very high? So what she has is now, and she is genotype 4. So then can you completely summarize the diagnosis what she has now? And let's look at all the. Can you just highlight the problems or give me a diagnosis on this?
So, case of cirrhosis of liver, chronic hepatitis C virus related, previously treated with DAA, but status.
So she's got decomposite chronic liver disease. Comorbids are hypothyroidism. She's got decomposite chronic liver disease.
Etiology.
Treatment for HCV. She's got cirrhosis of liver. Then
complications are.
No, she's got portal hypertension.
Spontaneous bacterial empyema and spontaneous bacterial empyema and glomerulonephritis, probably glomerular disease due to hepatitis C virus. And another is most likely reactivation of hepatitis C or inability.
She's got an active HCV infection now. We don't know whether she really achieved SVR or she had not achieved SVR, or it could be a relapse of the infection. Right? Can we have the next slide? So problem she has is HCV related cirrhosis, portal hypertension. She's got hypothyroidism. She's got decompensated hepatic SBE, nephrotic proteinuria, which could be membranous or a membranous thing, and she has got a HCV relapse. Okay. You think this hepatitis C itself could have produced glomerular disease?
Yes, sir. Yes, sir.
Yeah, it's possible, isn't it? And she doesn't have any. So we have ruled out diabetes. She is not obese. We don't know whether she has got NASH or not. She doesn't take alcohol abuse, but risk factors is she's above 60. Risk factor again, she's only a female, and she has got she has now very active HCV infection. Okay, and we don't have any evidence of any other autoimmune liver disease because ANA-IF, ANA profile and liver profile is negative. By CT scan, we have ruled out HCC and a portal vein thrombosis. Right?
take up the management.
Yeah, so can you now, I'm not going to open my mouth. So can you tell me, so there are so many, so we need to manage her decompensated liver disease. We need to manage her hyponatremia. We need to manage her hepatic hydrothorax. You need to give SBE. You need to think, how do we approach proteinuria? And now she's got a high HCV infection. So is it HCV resistance, or how do we treat this relapse? So tell me quickly, because I need to take one more case. So another 5 minutes. Tell me.
For management of decompensated chronic liver disease, I will first ask for fluid salt. I will give in 4.6 to 6.9.
What is it?
Sir, salt restriction in form
One is nutrition, isn't it? What are the gross points in nutrition?
Sir, calorie intake should be 30 to 35 kilocalorie per kg per day, and with that protein intake of 1 to 1.5 gram per kg per day.
1.5 grams per kg body weight, 30 to 35 kilocalories.
And sir, midnight snake containing 200 to.
He's got hyponatremia.
So fluid restriction is advocated, but usually
Fluid and salt restriction.
Yes.
What else can you do for hyponatremia?
Sir, injection human albumin 20 grams.
Excellent. You can give some albumin for this. She doesn't have AKI. Albumin is her indicated in what are the indications of albumin in this patient?
Sir, one is if there is any acute kidney injury or serum sodium level is below 117.
Yeah, one is hyponatremia. Other indication is spontaneous bacterial empyema. He's got an infection. You can give albumin even non-SBP related infections in patients with chronic liver disease. So hyponatremia can be managed with, so you will give her nutrition, you will restrict her salt, you will restrict her fluids, you will give her albumin, then you will give her a nighttime snack. Okay? You will take a nighttime snack. Then you will manage hyponatremia, the salt and fluid restriction, and albumin. Would you like to give her any natriuretic agent?
Sir, for now, I will not give 125 sodium, but once patient sodium improves, then I will start her on.
Yeah. What are the problems of natriuretic agent in patients, elderly patients?
Sir, hyponatremia can cause drowsiness. It can also precipitate hepatic encephalopathy.
No. What are the problems a natriuretic agent can cause in elderly? They can cause microhemorrhages in the brain. They can cause sudden hypernatremia or increased thirst. Sudden hypernatremia can also produce CPM4. And you should never discharge a patient on natriuretic agent thing. You should always be given only in the hospital. Now tell me the broad outlines. How do you manage a hepatic hydrothorax?
Sir,
2020 updated guidelines.
Sir, I will. Sir, for hepatic hydrothorax, primary treatment is paracentesis, and for
hepatic hydrothorax, do you do paracentesis, or when do you do paracentesis? When it's a large hydrothorax, do paracentesis.
Moderate to gross pleural effusion.
Can you put a pleural tube in hepatic hydrothorax?
Pigtail can be kept in.
Can you put a pleural tube, or can you do? So what are the broad? One is that, like any other ascites, you will put a salt and fluid restriction. Can we put a pleural tube in hepatic hydrothorax? Do you know? You don't know.
Yes, I know.
We generally avoid pleural tube because it's a very high source of infection. So generally you try to do a paracentesis. Name the drugs which can be used for hepatic hydrothorax. Can you give something subcutaneously? You can use octreotide. You can also give albumin. And then you can control hepatitis just like you control ascites with diuretics. But here you can't use diuretics because patient is already hyponatremic. What other things, if a patient has got a significant hepatic hydrothorax and is becoming sarcopenic, What is the other treatment you can do for hepatic hydrothorax? Tips can do. Tips will bring down hepatic hydrothorax. At the same time, it will also improve the nutrition of the patient. When will you not do tips?
Sir, when patient's CTP status
The patient's bilirubin is more than
3 milligram per deciliter and
more than 5, and if your MELD is more than 24, you will not do tips.
CTP score more than 13 that time.
Or if the patient has had any recurrent encephalopathy, you will not do tips.
Any
How do you manage SB?
SB, sir, I will also send pleural fluid culture and sensitivity, and I will start patient.
Now, will you take and wait for the culture, or you will treat with the empirical
will
antibiotic?
immediately start empirical antibiotics.
So you start empirical antibiotic, then change over the thing. Which has got a better prognosis, SBE or SBP?
SBP, sir. SBP, sir.
SBP has got a better prognosis. The onset of hepatic hydrothorax and SBE heralds a much more severe liver disease and decompensation.
Professor Venkat, it's 9 o'clock.
Sir?
9 o'clock, we have one more case.
Then how do you manage, what do you want to do with the proteinuria? Just another 5 minutes, sir.
For proteinuria,
you want to give steroids?
Nephrotic, but sir,
in this patient, if you treat hepatitis C, the proteinuria will come down. Now here is a patient who has already been treated. She's genotype 4. So how do you treat her relapse now? And do you regularly check for resistance in hepatitis C?
No, sir. Regularly we don't check.
No, we don't check because what is the resistance rate of hepatitis C for the first line?
Less than 1 to 2%.
Correct. 2.5 to 3% is only the resistance. So we don't really check. The resistance is commonly due to NS5A drugs or NS5B drugs.
NS5A.
NS5B doesn't get. Sofosbuvir does not get resistance. It's only in NS5A or protease inhibitors. Okay. So here now patient has got a HCV relapse. So in our country, how do you treat HCV relapse? Supposing this patient has been given sofosbuvir and valpetasvir. Now her live thing, so probably she had supposing she has resistance, she has relapsed. Now what drugs you will use in our country?
Sir, we can use.
We'll use the same drug.
Sir, same drug, but with ribavirin, we have to add sofosbuvir.
No, we'll use the same drug, or will you use the same valpetasvir or sofosbuvir, or is it better to use some other drug?
Better to use some other drugs.
Yeah, better to use some other drug. So in this case, you can use sofosbuvir and daclizumab, and as you said, you can probably use ribavirin. For how long you will give for these patients?
Sir, for 24 weeks.
24 to 36 weeks if it is genotype 1 and 4, 24 weeks for genotype 3. Okay. So this is a broad outline of this case. So when you have a patient who has been treated for hepatitis C and comes back with a decompensation, you need to look at what are the liver related causes for decompensation despite SVR. Rule out HCC prothrombin, look for relapse, look for autoimmune liver disease associated or any other autoimmune liver disease which has driven the decompensation now. And you should know for which you will get resistance, and you should know what will be the line of management this time. But if you have other drugs, do you know other drug which can be used, which is not available in India? What will be the best drug to use for her? You can give an 8 to 12 week therapy.
Clacaprevir.
You should look at other drugs also. You can give glaciprevir or pyrimidisvir for this drug so that you can get 8 to 12 weeks when there is, or you can use a 3-drug regimen. You can use sofosbuvir, valpetasvir, and voxeloprevir, a protease inhibitor like voxeloprevir. So now the present indication is when you have a resistance, you can go for a 3-drug regimen. You can do oxaloperavir, pirindavir, or sofosbuvir and velpatasvir. If you use 3 drugs, you don't use ribavirin. But in our country, probably we'll just change a little of NS5A and add ribavirin. And if it is type 1 or 4, we go for a 36-week therapy, or the thing will be a 24-week therapy in this patient. Okay?
Fine, we can move on to this. Thanks, Vivek. Be more confident in your presentation, okay? A little hesitant. You read a lot about HCV. These are the types of questions that you'll ask, okay? We can move on to the next. Who's the candidate? Next case.
Thank you, Dr. Vivek. Next resident to discuss is Dr. Jagdishwar from KIMS Trivandrum. Dr. Jagdish, please.
We take this as a short case. So I take through the history, okay?
Jagdish, are you there?
Yes, sir, I'm here, sir.
Okay.
So
Madam,
keep your audio
is
video
there
on.
any other comments on the previous case? Just we'll finish out.
No, previous case is fine. Yeah, previous case, I think first is the diagnosis and then the renal manifestations of HCV is very important. And the hepatic hydrothorax. I think the concentration will be on management of the empyema and the renal parameters. I just wanted to ask, in proteinuria, ribavirin is not contraindicated, is it? Ribavirin and proteinuria.
Anemia is contraindicated. I don't know about the protein. I need to check on that.
Yeah, I was just thinking.
I'll check on that, ma'am. I'm not very sure. Ribavirin.
Okay.
If you have anemia, ribavirin will enhance anemia.
Yeah.
Because
hemoglobin is 10.2, so I was just wondering about that, and proteinuria.
But here, I think the treatment of hepatitis C will suffice the protein. Many times, these lesions settle down once you treat hepatitis C in this patient.
Jagdish, can we move on?
Yes, ma'am. Can I start, ma'am?
I'll go through the history fast so that we need to manage this patient. Okay, 59-year-old female.
Predominantly, this case is predominantly a management issue.
Management. So she's a diabetic with a past history of hysterectomy, presenting with right upper quadrant abdominal pain, constant pain with mild weight loss. And she's on treatment for diabetes for 15 years and no other symptoms. Okay. Any comments?
Ma'am, this type of upper quadrant.
Dull continuous pain.
Dull, persistent right upper quadrant pain, mild weight loss.
Quick, you have to move fast.
Old chair for diabetes for 15 years.
Yes, ma'am. Is there any associated with any issue of jaundice, pruritus?
No jaundice. No, I mean, if that was there, it would have come up. No jaundice, no pruritus. Yeah.
This patient has come to us this is the history we got when she came to us in December 2020. Okay.
Oh, okay, sir. The duration of upper quadrant pain, sir?
All for about 3 weeks to 1 month.
Associated with any history, no vomiting and
no vomiting.
Any postprandial fullness or abdominal distension?
No abdominal, but she's got a vague pain in the right upper quadrant.
What are your differentials, doctor, for the vague abdominal pain in the right upper quadrant? Continuous pain. Pain.
Yes, ma'am. Known diabetic. First initial differential diagnosis, cholecystitis.
Cholecystitis. Okay. Is that the presentation? No. What are your differentials for a right upper quadrant pain? Continuous pain, dragging pain.
Dragging pain, like liver abscess is possible, ma'am, and infectious causes, inflammatory causes, and neoplastic causes.
Don't give a differentials like this. In a patient like this, what will be a differential? Patient comes to you to the OP and says, I have a dull dragging pain on the right side. What are your differentials in the outpatient clinic? No jaundice, just a continuous pain.
First differential diagnosis must be some liver abscess or chronic cholecystitis.
Any other space occupying lesion can present like this?
Yes, ma'am. Hepatocellular carcinoma or intrahepatic cholangiocarcinoma and GB gallbladder carcinoma also presented with abdominal pain.
Any other SOLs?
Pancreatic
Pancreatic. In right upper quadrant. Pancreatic.
Head of the pancreas SOL.
And head of pancreas SOL will come with pain in the right upper quadrant. This is where you will have problem. Is that the presentation of an SOL in the pancreas head mass?
No, no,
What are
ma'am.
the others? Fibroadenomas, and you can have fibrolamellar, that's not in this age. And you can have FNH. All these are space occupying. You have a dull dragging pain. So any mass lesion in the liver or a mass lesion in the gallbladder is the one that will give you a differential of a constant pain. It's not uncommon. No patient with large fatty liver, they'll also have a dull dragging pain on the right. So it's
Yes,
very
ma'am.
common. A large hepatomegaly, massive hepatomegaly, then have a dull dragging pain in this. So it can be infiltrative or it can be a space occupying. Next slide. Next slide. Don't, for heaven's sake, SOL pancreas.
Okay.
She's received
1
15
unit of
she's transfusion 15 years back. Okay, and she was found to be HCV positive. Ultrasound shows coarse liver, genotype 3. HCV RNA viral load is this. What should you do next? What's your management? What are your thoughts? Any other investigations you want? And what's your, where are you heading towards now?
So here in 2015, she was found to be HCV positive. She's a diabetic. She had a coarse liver. She had no evidence of any. She had a mild splenomegaly. She didn't have any decompensation. Genotype 3, 2015.
Yeah, and now she's
Is it the ultrasound of 2015 or the current ultrasound?
2015, she
It's
had.
the old ultrasound. Okay.
Yes, sir.
The ultrasound is 5 years earlier, no? Is it
What's
the
it?
current ultrasound or latest ultrasound or the old one?
No, this ultrasound was done in 2015. 2015,
Okay.
patient was found to be HCV positive. Ultrasound showed coarse liver, genotype 3. HCV RNA viral load was 63,80,614 international units. This is in 2015.
What happened after that?
So such a coarse liver, high viral load, vague pain. You want to do any imaging?
Yes, sir. I want to do CT liver angio, sir.
CT or can we go to the next slide?
Ask for an alpha fetoprotein.
We got a, this is on 28th September 2015. We got an MRI done.
Yes, sir.
Chronic
MRI showed
one minute. Chronic liver parenchymal disease with portal hypertension, no focal lesion in the liver. Okay.
The chronic liver parenchymal disease with portal hypertension. Okay. So in 2015, she had a coarse liver. She had chronic parenchymal liver disease by MRI. There was no SOL. She had a very high count. And in 2015, we had only ledipasvir. Okay. We did not have daclidazavir. We had only sofosbuvir, not LDV. We had only sofosbuvir. 2014 October, I think sofosbuvir was given after the ASLD. So only sofosbuvir was there. So at that time, the EASL guidance said that you can use PEG interferon. She was genotype 3. So we gave her PEG interferon. We gave sofosbuvir and ribavirin for 6 months. She had early virological response with undetected HCV. What do you mean by early virological response? At what week?
Sir, 4th week after starting antiviral, we need
4 weeks she had early virological response with undetected HCV RNA. So those days before the sofosbuvir before the DAA has come, early virological response, if it is there, that means you can continue the treatment. Okay. So we continued the treatment for 6 months, and at the end of the treatment, she had a viral load was undetectable. So she had HCV cirrhosis, she had HCV chronic parenchymal liver disease, very high count, and she had almost near normal platelet count, and she had end of the treatment response in early late 2015. By December 2015, she completed PEG interferon, sofosbuvir, and we gave her, because she had cirrhosis, we gave her 600 milligrams of ribavirin. Can we have the next?
So now what do you think has happened to her? Why should she come? What do you think has happened to her?
2015, 16 Jan, for 5 years, how will you follow up this patient?
Because already she developed some post liver, so I need to keep her in surveillance, sir. And
what is your surveillance plan?
Surveillance plan, I'll repeat the ultrasound abdomen and alpha fetoprotein levels every 6 months. Yes, sir. And I want to check the HCV RNA levels also every.
The HCV RNA level at the 24 weeks was undetected. So she had undetected HCV RNA at 24. She achieved an SVR 24.
Yes, sir.
Why would you ask for an HCV-RNA surveillance? You'll ask, is it? HCV-RNA?
So we end of the treatment was negative. Then SVR12 and SVR24 was achieved on her. And she continued to be SVR negative till now. So, but actually, what does the guideline say is once you are 24 weeks negative, you don't retest them.
Don't retest them, yeah.
You don't retest them, isn't it?
Yes, sir. Yes, sir.
12 weeks or 24, you don't retest them. So, but you follow up this patient because
Because
why do you want to follow up this patient?
because of chance of getting
No, she has
only
got a coarse ecotexture of the liver, so probably she might have an F3 or F4 fibrosis. And so the chance of your HCC even after SVR is
high.
still high. So you keep them on surveillance.
Yes, sir.
How many years you will keep in surveillance in this particular patient? And then you say no need for surveillance.
Surveillance of hepatocellular carcinoma or hepatitis?
Oh, yeah, you are going to do a surveillance for hepatocellular carcinoma only. You are not going to do anything. How long you will? So this patient has got either F3, F4 fibrosis. She has got SVR, and you want to follow up this patient. How many years you keep them in surveillance? And after a particular period, you said, okay, no need for them. But what I'm trying to tell you is, after how many years you will say that the risk of HCC will diminish in her after SVR?
Actually, I want to continue lifelong surveillance. I don't.
No, you can give it for 10 years. You can give it for 10 years. And if you find that she's only in F3 fibrosis and it's only 10 years, and after that, you may be able to say that probably she may not have think of the thing of it. What is her chance of getting her risk of HCC in her is about, I told you, 1.57% per year once reaching SVR. Okay, so how do you, next slide. So he was followed up with a 6-monthly ultrasound, LFT, serum alpha fetoprotein, December 2020. 2020 she presented with the present symptoms, vague upper quadrant pain. That's all. She came to us and this is the symptoms which we told you first, but she was religiously followed up till December 2020. And December 2020, she presented with these symptoms. Clinical examination was nothing remarkable.
Okay, sir.
Look at this.
Investigation hemoglobin 11.9, total count 5,200, platelet count 1,12,000, sir. Thrombocytopenia is there, and platelet prothrombin time 1.1, LFT 1.6 direct bilirubin, AST LT normal, alkaline phosphatase normal, and
all are normal. It's not baseline. All are normal.
LFT is normal.
Alpha fetoprotein is 5.6.
Urea is 23. Creatinine is active. She had
alpha fetoprotein is also normal.
Alpha fetoprotein. That means she has a well compensated child A. Child A cirrhosis.
Yes,
with
sir.
a low platelet count. Low platelet count was less than 1,50,000. Okay.
Yes, sir.
Just tell us the finding on ultrasound.
Then we did an ultrasound abdomen. In the ultrasound abdomen, do you see something in the right lower end?
So there is one hypoecho.
There is a small hypoecho here. No,
this is the one.
Here. Down,
Yes,
down, just below the thing. In the segment 6.
Okay,
Segment 6. Here, close. Sorry, I don't have the somewhere around here.
I think the second one it is seen better. Lower down.
Yes.
Here, segment 6. You see a small hypodense area.
Yes, sir.
And you see that there is a dilated portal vein here. Okay. So she's got a portal hypertension. There's a small lesion. So what do you do next?
Next,
endoscopy showed grade 2 varices, grade 1 to 2 varices. Can we go to the next slide? Then what do you do next?
CT liver angio, sir, with triple phase.
CT abdomen. We asked her to do, but she didn't do it in our hospital. She got it done because of some money issue. She got it done in Coimbatore Medical College Hospital then.
Yes, sir. So CT abdomen shows arterial enhancing lesion in segment 6, 2 into 2 centimeter lesion, early venous washout, no portal vein thrombosis, consistent with HCC in segment 6. Sir.
So here is a lady who's got post SVR. Can we go to the next slide, please? She's got a HCV related chronic parenchymal liver disease. She's definitely got a portal hypertension. She's got low platelet count. She's well compensated. She was child A, MELD 8. And she's got a now, and she has been on follow-up and she has achieved SVR. Her HCV RNA even in November 2020 was also undetected. And now she developed a small lesion in this one.
How do you manage?
This is exactly why we did an MRI. Now it has been indicated that if you are suspecting a chronic liver disease either due to a fibrosis or cirrhosis, when you are treating for and you have a HCV positive with active infection, it is possible that before you start the treatment, you do an MRI and see whether there's any small focus of dysplastic nodule. Wonderful study from Guru Prasad Aital. When they went back and saw all those MRIs, there were some subtle changes in that particular segment before you started even so so here this is a patient has got HCC following an SVR.
Yes, sir.
So she's 2.2 lesion, child A.
Yes, sir.
Grade 2 varices, low platelet count.
Manage, doctor?
So at that, how do you manage this patient?
Sir, her performance status now?
Good, very good. No? Performance is very good. Albumin is good. She is good.
Yes, sir.
BCLC, this is stage.
Sorry, now it will be early stage, sir. Early stage.
Tell me BCLC, man. Don't tell me early stage. In BCLC,
yes,
what is it, stage A, B, or C, or D?
Sir, stage A, sir.
Maybe stage A, 2 centimeter or less than 2 centimeters. Performance status is good, but she's got hypertension. Can we resect her?
Sir, because we need to see other features of portal hypertension. If portal hypertension,
she's got varices.
Yeah, grade 2 varices and ascites.
I said child A. I said she's child A. She's no ascites.
Yes, so
no ascites. She's child A. PTINR is 1.13. Platelet is 1,12,000.
And
can we resect her?
Yeah.
Because it's more chance to get decompensated, sir, when resection, because we need F3, F4 fibrosis. So better to go for
hypertension.
Yes, sir. So better to go for.
You expect the HVPG to more than 10.
Yes, sir.
10 or 12. So at that point of time, we don't really resect when the patient.
So we need to go for local ablative therapy, like radio frequency.
Local ablative therapy. Or you can go for a
radio frequency ablation or microwave ablation, sir.
Microwave thing. We could not do microwave or RFA mainly because they felt that it was too close to the portal vein. You can see in the segment 6, just below the portal vein. Okay.
So, and then we can give other option like liver transplantation, sir, because it's a single lesion less than 5 centimeter.
Patient is child A. So what is the role of TACE versus liver transplantation in BCLC-A?
Sir, she's under Milan criteria, so she
what
better.
What are you talking, doctor? Where is the Milan criteria comes here? She is 2.2 centimeter lesion. She's got a portal hypertension. She's child A, no ascites. She has never bled. If you want to, can you postpone the transplant? What is the survival rate between a TACE and a liver transplant in a patient who has got a BCLC-A? I'm just asking you, give me what will you happen to TACE? How long she'll survive?
Sir, liver transplantation.
So every HCC you should do a liver transplant, is it?
No, sir, not like that. In this case, if you will do the liver transplantation, it will be both curative treatment. But
MELD is 8.
sir, we can take it as an exception if some.
Well, if you can say, then why did you say low ablative therapy?
Sir, the low ablative therapy is also is a curative treatment for hepatocellular.
Ablative therapy is not curative. Ablative therapy is not curative. First 3 years, ablative, curative, and liver transplant will be at the same survival. After 5 years, liver transplant is much better. Okay.
Okay, sir.
So if you're not able to do, you can always do a test kit. You can do, what is the other therapy you can do? What is the other local regional therapy you can do?
Alpha.
What is the other local regional therapy you do apart than ablative therapy?
Sir, TACE and TARE.
TARE, why do you want TARE when there's no, I'm telling you, there's no portal vein thrombosis here.
Yes, sir. Only TACE only, sir. Transabdominal chemoembolization.
Can you do this next? Can I see that? Can you go to the next? Next slide, please. Since it was very, very close to the portal vein, we went ahead and did a TACE. Remember, these loco-regional therapies, you can give them or offer them because HCC is small growing tumor. If you can postpone the immunosuppression by 1 or 2 years, it will be much better for the patient, isn't it?
Yes, sir.
Here we do LDLT, so we get away with all those things. But elsewhere, she has to get a liver. Nobody will waste a liver in this. So what do you see here?
Here, liver angio shows the feeding vessel to the tumor, sir.
There's a big tumor blush here.
Yes, sir.
You can see a tumor blush, and you can see that the catheter is going in. Then the next, can you have the next slide? You will see. So this was done in December 30th, 2020. Can you go through this?
Sir, angiogram revealed a tumoral blush supplied by the superior branch of right hepatic artery. The culprit artery was selectively cannulated using Asahi Chikai microcatheter, and transarterial chemoembolization was performed using 50 milligram of adriamycin loaded Hepatitis particles. Check angiogram revealed obliteration of the tumoral blush with patent rest of the celiac artery branches. Impression, HCC right lobe of the liver. TACE successfully performed using 50 mg adriamycin loaded Hepatitis particles.
Okay. Now, how do you follow up this patient?
Uh,
when do you do the next imaging?
Sir, next imaging I will do after 4 to 6 weeks to see the.
4 weeks, yeah. Can I have the next slide?
Next slide.
Next discuss the follow up the patient. Is that the first CT will be done after
4 to 6 weeks.
4 weeks.
Yes, sir.
Can we have the next slide, please?
And there is no arterial enhancing lesion, sir. There
no
is
arterial enhancing. This was done on Jan 28. She has underwent a TACE on December 20. Jan 28. It's absolutely okay. What else you will follow up on? Or?
Sir, now again I'll ask her to repeat imaging after 3 months and then every 6 months, sir.
Yeah. So we told them after 3 months and then after 6 months. But unfortunately, there was a lockdown. And are you interested in alpha feta protein?
Sir, initially it was normal. So, yes, sir, I would like to.
You need to follow them.
Yes, sir.
When do you think will you assess the risk of recurrence? What are the parameters which will tell you there can be a risk of recurrence of HCC?
Sir, risk of recurrences in this patient will be.
No, you're following the patient. Tell me the parameters which will tell you that there can be a risk of recurrence.
Rising.
Answer. Time is
If
running.
your enzymes are persistently elevated,
Okay, sir.
and if your alpha fetoprotein is persistently above 6,
Yes, sir.
you can have a risk of recurrence. Okay.
Okay.
So that's why we need to check this. So this is done on Jan 24th. You will find that there's only post-taste changes. She didn't come back to us, but there was a huge lockdown, and she came to us on July 6th. We got a CT done. July 6th of 2021. She was supposed to come back in April, but April there was a lockdown and she could not come back. She came to us in July 6th, after 6 months.
Just tell the findings.
What do you see here? What do you see here?
There is an arterial enhancing lesion in segment 4, sir.
Segment 2 bordering 4. Okay.
Yes, sir.
Initial thing, and you will see in segment 6 there is completely no enhancement.
Yes, sir.
But in segment 2 and bordering segment 4, you have an arterial enhancing lesion. Can we go to the next slide?
Impression, chronic liver parenchymal disease, well-defined arterial and venous phase enhancing lesion with mild delayed washout and thin capsular enhancement in the segment 2 of the left lobe of the liver, suggestive of hepatocellular carcinoma, ill-defined non-enhancing hypodense areas in segment 6 of right lobe, post-taste changes, mild dilatation of liver.
What could have been the risk factor for recurrence in her?
Sir, HCV related fibrosis only.
CV is the thing. What is the other risk factor she has?
One more, age is the one more risk factor, sir.
Age is 59.
And diabetes.
Interestingly, I'll tell you, the previous patient which I discussed was her neighbor. The previous HCV patient I discussed,
yes, sir.
Her neighbor. Okay.
So
previous patient, no, the first case was her neighbor. So now her risk factor here is diabetes. Okay.
Yes, sir.
Diabetes. She's been a diabetic for 15 years.
Yes.
And as I told you, if they have a persistent elevated transaminitis and alpha, the risk of recurrence is high. So now there is a thing. And here in the CT, we show that there is the right lobe is much more shrunken now.
Yes, sir.
So possibly her persistent diabetes, there may be an element of metabolic lifting. So we decided now that we will offer her a.
Next slide.
Sir, there will be a branch portal vein
What is the
thrombosis.
treatment now we can offer her now? Can
now,
we go to the previous slide? Previous slide.
Sir, there will be a right branch of portal vein is smaller caliber, non-enhancing of peripheral branches.
We did an MRI. Now, what do you offer her? Do you think can we repeat a TACE, or what is the best option now?
Now, best option will be we can go ahead and do the TACE, sir, because there is a portal vein thrombosis.
Because there's a portal vein thrombosis, liver lobe is much more shrunken now.
Yes, sir.
So the best thing, as we said, is we offered her TACE, or in the MDT, we decided that she could go for a
Sir, liver.
There's a recurrence, so it can go for a
liver transplantation.
Liver transplantation. Okay.
Yes, sir.
Since she had a very early recurrence, we thought we'll go for a liver transplant because the right lobe is shrinking. So we do an MRI because they were a little worried about it nearer to the capsule. So in the MRI, it showed again a sick. But there was, why we did MRI was the CT showed 2 or 3 multiple nodules in segment 4. They were not very sure that was a multicentric HCC. So we did MRI. MRI showed only a segment 2 lesion, which is about 2.9 into 2 into 1.7 centimeters. And there was a capsular retraction in this. Now, do we routinely do PET scan in patients with HCC, or what is the indication for PET scan?
Sir, routinely we don't do the PET CT in.
Why did I do a PET scan here?
Sir, only thing to rule out any extrahepatic metastasis. Planning for liver.
If you are planning a liver transplant, That's the time when you do a PET scan.
Yes, sir.
You never asked me what is an alpha fetoprotein.
Yes, sir. Yeah.
Or alpha fetoprotein now this time was 17. Was 17. So we did a PET scan. So the PET scan showed
FDG a bit subcapsular partly exophytic arterial enhancing lesion with venous phase washout in the segment 2, 4A of liver. Low FDG a bit chronic thrombus in the anterior sectoral branch of right portal vein. Non-FDG a bit ill-defined hypodensity with overlying capsular obstruction anterior segment of right lobe of liver, likely post-treatment changes. Non-FDG a bit sub-centimeter size arterial enhancing focus with the persistent venous phase enhancement in segment 4A of liver, likely regenerative nodule. No other abnormal metabolic activity noted elsewhere in the whole body.
So what she has is now a segment lesion. There's a completely lesion in the right lobe is completely gone.
Yes,
the
sir.
most important thing, the thrombus in the right portal vein is not non-tumoral thrombus. That's exactly why we do this thing. Okay.
Yes, sir.
Now we have taken up this. We have counseled her for a liver transplant, and they have agreed. That's exactly why we did it. So issues with this thing. So let me ask you this: what is a? I've already discussed the HCC occurrence in post-SVR HCV patients. Okay, HCV recurrence. In this case, you should always remember. But if a patient has got F3, F4 fibrinosis despite SVR, you have a 1.57% of risk of HCC every year. And if your SGOT is always elevated, and if your serum alpha fetoprotein during surveillance is always more than 6, or after a TACE or ablative therapy, if your serum alpha is more than 6, then you have a chance of recurrence. So treatment of HCC recurrence in this patient is because it was an early recurrence, we offered her a transplant. Okay, offered her a transplant. So what is the Milan criteria?
Milan criteria.
Let them read it, LVK, that they would answer, LVK. Any other thing? Time is almost running out.
Madam?
Time is almost running out. Milan criteria and all, they will say, you can ask some specific.
What is Milan criteria?
Yeah, specific question here.
Milan criteria, single lesion 5 centimeter or 3 lesion less than maximum size 3 centimeter.
So in the transplant now 2020 or 2021, do you think there are rules have changed?
Yes, sir.
You go only Milan criteria, what else you go?
Sir, there is Milan's criteria, there is a universe.
No, supposing somebody has got, what is the other parameters now you take to decide on the transplant for HCC apart from Milan criteria?
One more is alpha fetoprotein level, sir. If more than 1000
protein.
Performance status?
No, that is BCLC. Now for the liver transplant, you have decided on liver transplant. You go, one is Milan criteria. The second is you go by the what you said is alpha fetoprotein levels. You want to look at the biology of the tumor. You can look at the neutrophil lymphocyte ratio, and then you can also look at the descarboxy prothrombin time. If these things are very, very high, supposing it is like this, what is the normal survival of a patient in a liver transplant for HCC? Within Milan?
Within the Milan, 5 year survival rate 70 to 80%, sir.
80%. Survival is thing. So it is like this. If somebody has 7 centimeter tumor,
yes, sir,
and you have a 5 and your AFP is 5.
Yes, sir.
Versus if somebody has got a 4.5 centimeter tumor with an AFB of 400, whom do you think has got a better prognosis?
7 centimeter tumor with alpha fetoprotein 5 is the better.
The probability of the survival of a 7 centimeter tumor with a 5 AFP has got a 70 to 75% survival, versus a Milan who has got within Milan criteria 4.5 with a 400, this thing who has got only 60%. So what you need to do is when if your alpha fetoprotein is more than 1000 according to the ASLD, or according to the Asian things or Japanese thing, if it is more than 400, you always downstage the tumor. So when you downstage the tumor by a loco-regional therapy, and when you downstage the treatment, then only you can go for a transplant. So 7 centimeter with 5, you can downstage it and do a transplant. It's got a better prognosis than somebody who's got this one. This is what is now the present thinking of liver transplant and HCC. Do we treat HCV in the presence of HCC? Supposing somebody has got HCC, child B, ascites, jaundice, high viral load. Should we treat or should we not treat?
Sir,
what is the correct state of thinking?
LVK, please answer.
So in a patient who has got, previously we thought if you have an active HCC, you don't treat because your response rate for this one is low when you give DAA. At that time, we had only one drug, either sorafenib or lenvatinib. Now you have an array of drugs. So what people think now is, if it is like this, if somebody has got HCV, cirrhosis and HCC, you look at which burden is more. If the tumor burden is very high, there's no point treating hepatitis C because he's going to die of a tumor burden. But if the tumor is small and he is decompensated, and if you think the disease burden is high, his decompensation is predominantly due to hepatitis C and decompensation, then you can treat HCV, downstage him from child B to child A or child C to child B, and then you can give him other chemotherapy. You know the other chemotherapies are available now, apart from sorafenib. So please look, the systemic therapy of HCC now, it is on a sea of changes. Now the present, what is the present first line drug? Anybody else can tell me what is the present first line drug?
Bevacizumab, atezolizumab.
Not lenvatinib.
Atezolizumab and bevacizumab.
Huh?
Atezolizumab and bevacizumab.
Atezolizumab and bevacizumab is the first line of drug. Your overall survival rate is much better. So if your hepatitis C burden is high, what you need to do is you can treat the patient with HCC, downgrade him, and then try to give these drugs for HCC. Risk factor for HCC recurrence after liver transplant? First thing is, if your alpha fetoprotein is high pre-transplant, more than 500 or more than 1000, then you have to downstage it and then do a transplant. Then you need to look at the explant liver. This is called the retreat score. It is called the retreat score. The retreat score look at the number of nodules you have in the explant liver based on 0 to 20, 20 to 40, 40 to 1. There is a score. Okay. Then the presence of vascular invasion. Presence of vascular invasion, if it is there or not. And these two things. So pre-alpha fetoprotein, explant number of nodules, presence of vascular invasion. There's one more criteria. Just go look at the retreat score for this HCV after the liver transplant. If the retreat score is more than say 6, then you have a very high chance of recurrence in the transplant. Okay, that's what you do. So this is the risk of recurrence in liver transplant. So in hepatitis C, the take-home messages are: number 1, despite having an SVR, if you have F3, F4 fibrosis and cirrhosis, you have a high chance recurrence of HCC. When you have HCC, you have treatment options if they are well compensated, local ablative TACE, and look for 3 years. And if there's recurrence within 3 years, go for a transplant. But after 3 years, transplant has got a better options. You should always, when you are following up, you follow up the imaging as you suggested, 4 weeks, 12 weeks, and 6 months later. Then if your alpha fetoprotein is always above 6 and SGOT is more than elevated, you have high chance of recurrence even after initial therapy. And do we treat hepatitis C? Initially they said no, but now depending on whether it's a tumor burden or is it viral burden, which is causing decompensation, I think you need to decide on the DAA, okay? If it is completely a tumor burden, which is causing the progressive decompensation, you don't treat. If you think the tumor is small, you can do it. You can downgrade it from child B to child A or child C to child B and then give them chemotherapy. And when you do a liver transplant, you should always put the retreat score to see if you have a high chance of recurrence or low chance of recurrence. If it is 0, the chance of recurrence in the next 5 years is 1%. If it is more than 5, the chance of recurrence is 5 years. If 5 is about 40 to 50%. So you need to put this score after a transplant to look at the explant and the preoperative alpha fetoprotein. So this is what I think is HCC and HCV. So we discussed 2 cases of HCV. One is HCV relapse, resistance, decompensation, associated renal injury, hepatic hydrothorax, SBE. And the other one is post-SVR HCC. Dr. Varghese and Madam, can you please comment on this?
Andy ma'am, any comments?
Just one. Is there a role of prophylaxis in this particular patient, empyema? There's one question there. Role of prophylaxis. LVK?
Madam?
Role of Norflox prophylaxis in SBP. Yes, that is your empyema.
I think it's the principle is almost like you treat an
SBP, yeah.
You do LBN, but definitely in hepatic hydrothorax, the protein content is high. As I said, the pleura absorbs more water. Your fatality rate is much higher, prognosis much poorer when you have SBE than SBP.
Then $1.10 has asked a question: can we give ARBs in CLD patients to reduce proteinuria?
What, madam?
$10, I don't know who the person is. I think they can just address the question. Can you ask the question? BT, what is that? That ARB, I don't understand what it stands for. I'm not well versed with the abbreviations.
S1, S10.
Yeah, $10.
Can we ARBs in CLD patients to reduce proteinuria?
Ribavirin, yeah.
Angiotensin
Somebody sent me an
blocker.
article saying ribavirin in post-transplant patient will reduce the proteinuria.
Angiotensin receptor blocker.
Like the other patient, when we put them
I will
on,
refer to the nephrologist.
Most of it cleared. Actually, do you have in hepatitis B? If you have a high viral load and proteinuria, when you treat hepatitis B, it becomes
all right. Nice case, LVK. Wonderful.
Okay.
Learning. We learned a lot.
Interesting cases, real problems in real life. Dr. Sojan, are you there?
Yes, I am here.
Okay, so
we had an extensive discussion.
Okay, next week we have a GA midgut bleed and IBD, and interestingly, Dr. Rupa Banerjee is also joining our class. Okay, so please remember to join our class. Over to Dr. Sojan.
Good evening to all.
Thank you, madam.
Good evening to all. We had a wonderful session today. Both the cases which were discussed were very informative, and I am sure that all our students would have benefited a lot. Once again, from the bottom of heart, on behalf of IST Kerala chapter, I would like to thank LVK sir for taking all the pains to come over here, and Jayanti madam, especially even in your uniform, coming over and giving us a wonderful session. Thank you so much.
I enjoyed the session. I cannot miss LVK's class. I'm a nephrologist now.
Ma'am didn't have any time to change dress.
I have a lot to learn from LVK. Thank you, LVK.
Thank you, madam.
On behalf of everyone, I would like to thank Varghese sir and all the students. Varghese sir for coordinating the session wonderfully well, and students for actively participating. Since it's late, I think I will stop with this. Thank you all once again.
Thank you.
Thank you, LVK. Thank you.
Thank you, sir.
Okay, good night. Good night.